Sir, I am in a Raisa, sir. Raisa, sir, and name has changed.
Okay, right. Okay, name is not good.
Okay, shall I share the presentation for you, Dr. Venkat?
Yeah. Has he prepared a PPT?
Yes, sir.
PPT.
He's presenting.
Yeah, okay, perfect.
Is it visible, sir?
Oh, not yet. The share. Yeah, it's full.
Over to Dr. Venkat.
Yes, sir.
I think this is not the first try.
No, sir.
Yeah.
Okay. Thank you, sir. Sir, good evening, sir. I am audible, sir. Clear?
Yeah, you are audible. Please go ahead.
Sir, today my topic is regarding blood, physiology of hemostasis, and laboratory testing of coagulation.
Very good.
I present my topic under following headings, starting with introduction, then what happens when there is a vascular injury and the response to vascular injury, followed by there are three interrelated important structures which are involved or play a vital role in hemostasis, that is vascular endothelium, platelet, and the plasma protein. Next, I will focus on intrinsic or anticoagulant mechanisms. What are counter-regulating mechanisms for coagulation? Followed by laboratory testing of coagulation. Lastly, point of care of coagulation testing. A brief note on point of care of coagulation testing. Coming to the introduction, hemostasis is an ordered, complex enzymatic process involving cellular and biochemical components that function to preserve the integrity of circulatory system of a vascular injury. These are complex interrelated systemic mechanisms and they operate to maintain a balance between a procoagulant and anticoagulant. The ultimate goal of hemostasis is to limit blood loss after injury and maintaining intravascular volume and promote revascularization after thrombus formation. So three important structures which are involved and play equal role are vascular endothelium, the platelets, and the plasma proteins. So any derangements in the above system can lead to excessive bleeding or pathological thrombus formation. So what happens when there is an injury? There are a series of events which occur due to injury. So vascular injury due to a mechanical or biochemical factors initiates these reactions. First, constriction of the blood vessels, followed by primary hemostasis. This is initiated by platelets, which forms a temporary hemostatic plague of platelets. These are sufficient for minor injuries, but when there is a severe injury, this platelet plague may not be sufficient to counteract the effects. So, which is done by secondary hemostasis, which are mediated by the plasma clotting factors to form a stable clot incorporating final cross-linked insoluble fibrin. Although the terms primary, secondary hemostasis, they are separate and relevant for descriptive and diagnostic purpose, but advances in molecular process suggest a far more complex interplay between the vascular endothelium, platelets, and the hemostasis. Coming to what is the role of vascular endothelium in hemostasis? In order to maintain a normal blood flow through circulatory system, the vascular endothelium employs several strategies to inhibit unnecessary thrombus formation. So Healthy endothelial cells possess antiplatelet action, anticoagulating action, pro-fibrinolytic effect to inhibit clot formation. So what are the effects? How is vascular endothelium do this effect? First, first thing is negative charges of endothelium repels the platelets. Second thing is endothelial cells produce potent platelet inhibitors such as prostacyclin, PGI2, and nitric oxide. Third thing is they secrete adenosine diphosphatase, that is CD39, which are present on the surface of vascular endothelium, will degrade adenosine diphosphate. Adenosine diphosphate is a potent activator of platelets, which causes platelet aggregation. And the active metabolite of prophylactic cells selectively inhibits this step, ADP binding to its platelet P2 vital receptor, and also the subsequent ADP mediated activation. So, and next is there is also a this vascular endothelium plays an important anticoagulant role through the expression of several inhibitors of plasma-mediated hemostasis by increasing the activation of anticoagulant protein C via glycoprotein thrombomodulin, which also acts as a thrombin-mediated activator. Fifth thing where it causes anticoagulant effect in normal vascular endothelium are there are several inhibitors released by plasma, as already mentioned. And endothelium bound glycosaminoglycans such as heparin sulfate also functions to accelerate the protease activity of antithrombin, which degrades factor 9, 10, and thrombin. Lastly, vascular endothelium synthesizes tissue plasminogen activator, which is responsible for activation of fibrinolysis, that primary counter-regulatory mechanism limiting clot formation. So 1 to almost 6 steps are present which prevent the thrombus formation in intact vascular epithelium. So what happens when there is a vascular endothelial injury occurs? This vascular endothelial injury exposes the underlying extracellular matrix, which contains collagen, von Willebrand factor, and platelet adhesive glycoprotein. So these platelets get bind and get activated when they are exposed to extracellular matrix components. And also exposure of tissue factor whenever there is an injury triggers the extrinsic pathway of coagulation cascade, which results in thrombin generation and clot formation. And also certain cytokines are also released whenever there is a severe vascular injury, such as interleukin-1, human necrosis factor, interleukin-1, inducing prothrombotic changes. Finally, thrombin, hypoxia, high fluid tear stresses can also induce prothrombotic vascular changes. Coming to what is the role of platelets and hemostasis. Under normal conditions, platelets do not adhere vascular endothelium. However, when there is an injury exposing the extracellular matrix, platelets undergo a series of biochemical and physiological alterations which are characterized by 3 phases such as adhesion, activation, and aggregation. Von Willebrand factor is an important bridging molecule between the collagen which is exposed during injury and a platelet glycoprotein 1B and factor 9 and factor 5 complexes. So platelets interact with collagen also serves as a stimulus for subsequent phase of activation. So during aggregation, activators are released, causes further recruitment of platelets and newly active glycoprotein 2B3A receptors on the platelets causes bridging of fibrinogen, thereby promoting cross linkages and aggregation, and there will be followed by increased aggregation of adjacent platelets to form stable platelet plug. So importance of these receptors 2B and 3A receptors is important in syndrome where there are deficit or absent, leading to a clinical condition leading to the transient thrombus. Coming to the what is the role of plasma mediated hemostasis. Plasma-mediated hemostasis was originally described as a cascade or waterfall sequence of steps involving a series of activation of enzymes and cofactors to accelerate and amplify fibrin generation by thrombin. Traditionally, it is depicted as extrinsic pathway, intrinsic pathway. Both of them cumulatively goes to common pathway. Usual coagulation factors are synthesized by liver and they are circulated within the circulation as an inactive protein called zymogens. So what does this coagulation cascade do is it creates a series of enzymatic reactions in which the inactive precursors undergo a series of activation to active form and to overall amplify the reaction. So the ultimate goal is to produce thrombin and finally a stable fibrin insoluble clot. So the key regulatory step in the plasma mediated hemostasis or coagulation cascade is thrombin generation, also known as the thrombin burst. So in the picture, you can see both the pathways, the extrinsic pathway and the intrinsic pathway. The extrinsic, whenever there is a vascular endothelial injury, tissue factor initiates this extrinsic pathway. Whenever this extrinsic pathway is stimulated along with tissue factor and which further activates factor 7, which in turn further activates 9 and 10. During intrinsic pathway, this intrinsic pathway usually activated is the intrinsic system, the conversion of factor 7 to an active factor 7A. So activation in vivo occurs when the blood is exposed to collagen fibers under the endothelium within the blood vessel. So activating factor 12 then further activates 11 and 11 activates 9. So activated 9 forms a complex with active factor 8, which is activated when it is separated from one bilirubin factor. All these complexes, both intrinsic pathway and extrinsic pathway, finally they will activate the factor 10 from inactive to active factor. So finally the extrinsic pathway is triggered by the release of tissue factor or tissue thromboplastin, which is a protein phospholipid mixture which activates factor 7. So third important step in plasma mediated hemostasis is activation, that is common pathway for coagulation. Both extrinsic pathway and intrinsic pathway, they form the kinase complexes which will activate factor 10. So what is this common pathway? Final common pathway to both intrinsic and extrinsic factors depicts thrombin generation and subsequent fibrin formation. So what are the signal amplifies these reactions include factor 9, 8 and calcium ions, which are very, very important to activate this overall step. Finally, they form the prothrombinase complex, which converts the prothrombin to thrombin. This activated thrombin converts the fibrinogen to fibrin monomer, and all these insoluble fibrin monomers combine cross-linkers along with platelets to form a stable clot. For the conversion of fibrin monomer to cross-linked fibrin requires factor 13, that is fibrin stabilizing factor. So thrombin proteolytically cleaves fibrinopeptides A and B from fibrin molecules to generate fibrin monomers, which polymerize into fibrin strands to form a stable clot. So as already mentioned, thrombin generation remains the key step regulating hemostasis. Not only thrombin activity mediates conversion of fibrinogen to fibrin, but it also has a host of actions like it activates platelets and factor 13, converts inactive cofactor 5 and 8 to active form, upregulates expression of tissue factor, and stimulates vascular endothelium of plasminogen activating inhibitor to down regulate fibrinolytic activity, and also suppresses uncontrolled thrombus through activation of protein C. So this thrombin not only converts fibrinogen to fibrin, but also does the host of reaction. This slide shows how the clot is synthesized and progressed. First picture shows the normal picture. Whenever there is a vascular injury, it initiates and exposes the extracellular matrix, which contains tissue factor and wall Williband factor, which initiates the binding of platelets to collagen tissue factor dependent, and also tissue factor dependent initiates the extracellular pathway, followed by propagation. In propagation, there will be recruitment of platelets to grow thrombosis and also amplification of coagulation cascade. And finally, due to formation of platelet plug interaction with fibrin deposition, it forms a stable clot. Next slide. So, what are the intrinsic anticoagulant mechanisms? Once activated, regulation of hemostasis proves essential to limit clot progression beyond the injury site. So, there are 4 important counter-regulatory pathways have been identified to down-regulate hemostasis. First is fibrinolysis. Next, tissue factor pathway inhibitor. Third is protein C. Fourth is serine protease inhibitor. In the picture, you can see the fibrinolysis. The fibrinolysis compresses a cascade of reaction which causes plasmin generation and causes proteolytic degradation of fibrin and fibrinogen. So, principal enzymatic mediator in fibrinolysis, plasmin. So, plasminogen is converted to plasmin under the influence of PAI, plasminogen activator, tissue plasminogen activator, which converts the plasminogen to plasmin or urokinase. This tissue plasminogen activator is inhibited by plasminogen activator inhibitor. And the antifibrinolytics such as tranexamic acid work at this level. It prevents the conversion of plasminogen to plasmin. So it is used as a reduces the bleeding. And plasminogen, once it gets activated, it converts the fibrin into fibrin degradation product and acts and as useful as an intrinsic anticoagulant. Next is tissue factor. Tissue factor and factor 8 form complexes to inhibit tissue factor, thus down-regulating extrinsic pathway. Next slide. Protein C system down-regulates coagulation by inhibiting thrombin and cofactor 518 by forming complexes with protein C. Next is most significant serotonin peptide inhibitors regulating hemostasis are antithrombin and heparin cofactor 2. This antithrombin inhibits thrombin factor 9, 10, 11, and 12. Heparin binds to antithrombin, causing conformational changes that accelerates AT-mediated inhibition. This heparin cofactor was recently discovered that inhibits only thrombin, whereas antithrombin, it inhibits not only thrombin but also other factors, whereas heparin cofactors was only inhibits thrombin. Next slide. Coming to the laboratory testing of coagulation studies. Traditionally, perioperative coagulation monitoring has focused on preoperative testing to identify patients at increased risk for perioperative bleeding. And secondly, there is these tests are done to intraoperatively monitor the heparin therapy during cardiac and vascular surgery. Coming to the ideal test for perioperative coagulation, it should be simple to perform, accurate, reproducible, diagnostically specific, and cost effective. But present, no current coagulation monitors meets these expectations. Hence, there is integration of results from multiple forms of monitoring which may provide valuable diagnostic insights into perioperative coagulopathy. However, the current evidence does not support the routine and selected coagulation screening, which has a limited perioperative outcome, may delay surgery, and patient is subjected unnecessary parented tests. So, if the clinical examination history do not predict any increased risk of bleeding, then abnormal coagulation study will result in unlikely results and need for routine screening should be checked. Next slide. So what are the specific laboratory tests for coagulation? It includes prothrombin time, activated partial thromboplastin time, platelet count and bleeding time, anti-factor 10A activity or factor 10A inhibition test, or thrombin time or leptilase time, fibrinogen levels, fibrin degrading products, and D-dimer. Next slide. Coming to the prothrombin time. What is prothrombin time? It is a time required in seconds for clot formation to occur after mixing a tissue factor, that is thromboplastin. So in prothrombin time, we will use tissue factor and calcium. So it assesses the integrity of extrinsic pathway. As already mentioned, extrinsic pathway is stimulated by tissue factor. So it assesses the integrity of extrinsic pathway and common pathway. This prothrombin time is sensitive to deficiency of fibrinogen, thrombin, factor 5, 8, 7 and 10. However, it is most sensitive for factor 7 and 10. When you see these factors, out of all, 3 factors are vitamin K dependent, that is 2, 7 and 10. So prothrombin time assay has been used to monitor anticoagulation with vitamin K antagonist such as warfarin. Coming to the INR. So thromboplastin, which is the reagent used during measurement of prothrombin at different labs, can vary in its ability to bind factor 7. So thromboplastin which is used will vary from lab to lab. So there will be inter-lab comparisons and also which will limit the prothrombin time. Due to this, the internationally accepted measures are developed by WHO, which include international normalized ratio, a method to a means of normalizing the PT results among different labs. INR is calculated by patient PT divided by standard PT, which is usually normally 11 to 13.5 seconds. So whenever there is any prolongation of PT, we should assess further why there is a delay in clot, due to whether it is due to coagulation factor deficiency in the patient's serum, or whether due to presence of any inhibitor such as antiphospholipid antibody or fibrin degradation products. How will you assess these things? First, you collect the patient serum and mix with the known donor patient serum sample. So whenever there is delay, it is due to antiphospholipid antibody. When there is no delay, it is normal. It is due to coagulation factor deficiency. Because in normal serum, the patient contains coagulation factor, which causes normal prothrombin time. But however, when there is antiphospholipid antibody, it is not present in donor, so it gets prolonged. What is the clinical significance of prothrombin time? As already mentioned, it is useful to monitor oral anticoagulant therapy with warfarin. Whenever the patient requires warfarin due to deep vein thrombosis or due to any condition, the therapeutic goal is to achieve 2 to 3 seconds. So when 2 to 3 seconds. So that prothrombin time normally is 11 to 13 seconds. 2 to 3, it comes upon 45 to 100 seconds. So this is the normal prothrombin time when the patient is on warfarin therapy. So based on these measures, we can adjust or increase or decrease the dose of warfarin therapy based on this prothrombin and INR ratio. Coming second important clinical significance is whenever the patient has vitamin K deficiency. So this prothrombin time is increased. And in case of liver synthetic function, decreased liver synthetic function also, prothrombin time increased. And the patient is having disseminated intravascular coagulation or decreased factor 7, also this prothrombin time is increased. Next slide. Coming to the activated partial thromboplastin time, APTT. It assesses the integrity of intrinsic pathway. Whereas PT assesses the integrity of extrinsic pathway, APTT assesses the integrity of intrinsic pathway and common pathway. This is the APTT is the time required in seconds for clot formation to occur after mixing the patient plasma with calcium phospholipid and the activator of intrinsic pathway, that kaolin silica cellulite. This test is more sensitive to deficiency of factor 8 and 9, whereas PT is more sensitive to 7 and 10. APTT may sometimes cannot prolong until the level decreases below 15%. And when unlike APTT, there are no standards for PT, there are no standards for APTT like INR. So institutions set their own normal ranges and cannot be compared between labs. The normal range is usually between 30 to 40 seconds. Coming to the clinical significance. So it is useful to monitor therapy when unfractured heparin is used, and it should be targeted at least 1.5 to 2 times the normal. And it is also useful for hemophilia A, B, and C. That is hemophilia A is due to factor A deficiency, B is 9, C is 11. And also it raises in conditions of lupus anticoagulant or phospholipid antibody syndrome. Coming to bleeding time and the platelet count. It remains one of the standard components in screening for coagulation studies, reflecting only quantity but not the function. So platelet count only quantitatively can determine, but not the function of the platelets. Usually normal range is 1.5 to 4.5 lakhs per cubic millimeter. Spontaneous bleeding is less likely with counts more than 10,000 to 20,000. Surgical bleeding may be severe with counts from 40,000 to 70,000. For certain procedures like neurosurgeries, bleeding can occur with count 1 lakh to 1.5 lakh. There are no current recommendation what is the safest level, but the current guidelines say more than 1 lakh causes normal coagulation, most of the cases. So satisfactory platelet plug will not be formed if the count is too low or functionally inert, such as during cardiopulmonary bypass or during blood stored more than 3 months, patients on aspirin or uremic patient. Platelet count is crucial for patients on prolonged therapy on fraction heparin, usually more than 4 days. So due to heparin-induced thrombocytopenia. Abnormal low platelet count requires further assessment like visual platelet count from blood smear to determine the actual cause. So sample hemodilution and platelet clumping are common etiologies for falsely low platelet count. Bleeding time will assess the platelet function and normally 2 to 9 minutes and measures the overall hemostatic role of platelets and primary hemostasis. Coming to anti-factor 10A activity. Anti-factor 10A activity or factor 10A inhibition test commonly used for heparin anticoagulation. These APTT values are also used for heparin. However, there is difference between both these countries. APTT values are usually affected by several factors, including patient factors, coagulation deficiency, or any factors inhibitors present. However, heparin bound AT inhibition factor 10 is not influenced by this variable. So it depends only on heparin and bound to antithrombin. So other advantage of this test is it is used to measure like other anticoagulation, not only unfractured heparin, but also low molecular heparin like enoxaparin or fondaparinux. The process involves combining the patient plasma with reagent. So look for factor 10A cleavage, which generates a colorimetric signal which is released and is functionally by calculating this we can functionally assess the heparin anticoagulation. Coming to thrombin time and reptilase time. Thrombin time tests the ability of thrombin to convert fibrinogen to fibrin. So normal value is 15 to 19 seconds. TT may be prolonged in conditions affecting the fibrinogen or thrombin. For example, in hypofibrinogenemia, when there is less than 100 milligrams per deciliter, or advanced liver disease, heparin therapy or direct thrombin inhibitor and fibrin degradation products. So in contrary to reptilase time, this reptilase is a venom used is an enzyme which is found in the snake venom. The action is similar to thrombin. So why this reptilase time is used? This reptilase time is used to distinguish between the effects of heparin and fibrin degradation products. So in the TT fibrin degradation products, normally this reptilase time indicates the presence of heparin. Elevation of both thrombin time and reptilase time denotes low fibrinogen levels or presence of fibrin degradation products. So whenever there is TT is prolonged, it is mostly due to heparin. When the reptilase time is prolonged, it is denotes mostly due to low fibrinogen levels or presence of FDP. Coming to the fibrinogen level, the normal fibrinogen level is 160 to 350 milligrams per deciliter, mainly produced by liver, and less than 100 milligrams per deciliter are inadequate. Low level reflects reduced production, as in hereditary hypofibrinogenemia, liver impairment, severe malnutrition, or due to increased consumption, as in DIC. Fibrinogen consumption without DIC is an important cause of severe bleeding in patients with blood loss after major surgery. Coming to FDP, fibrin degradation products and D-dimer. Measurement of this fibrin degradation product will detect the degradation products of both fibrin, both cross-linked and uncross-linked. So when you measure FDP, it indicates both cross-linked and uncross-linked. Whereas D-dimer specifically for degradation products of cross-linked fibrin only. So excessive fibrinogen results in increased FDP levels in conditions like advanced liver disease, exogenous thrombolysis, such as administration of streptokinase, and fibrinolysis during cardiopulmonary bypass. However, D-dimer reflects widespread lysis of cross-linked fibrin of established thrombosis, such as in DIC or deep vein thrombosis and pulmonary embolism. Normal value less than 250 nanograms per ml. Coming to the brief note on point of care testing. Point of care testing is a rapid specific testing of body fluids at bedside. Results can be obtained within minutes without delay, as in laboratory testing. So it offers opportunities to direct blood components and hemostatic drug therapy more specifically. Done with whole blood at patient's temperature, unlike laboratory testing which uses plasma. They are classified broadly into 4 categories. First is functional measurement of coagulation, that measures the intrinsic ability of blood to generate clot, that is activated clotting time. Next is heparin concentration measurements techniques, and third thing, viscoelastic measures of coagulation, the thromboelastogram and ROTEM, rotational thromboelastography. So fourth thing is platelet function monitor. So all these are broadly classified under point of care. The take home, normal hemostasis is the balance between generation of localized hemostatic clot and uncontrollable thrombus formation. The extensive pathway of coagulation begins with exposure of blood plasma to tissue factor and represents the initial phase of plasma-mediated hemostasis. However, the intrinsic pathway amplifies and propagates the hemostatic response to maximize the thrombus generation. The common pathway generates thrombin, forms fibrin, and cross-links fibrin strands to produce an insoluble fibrin clot. Routine preoperative coagulation testing of all surgical patient is costly and lacks predictive value for detection of hemostatic abnormalities. Testing should be based on the preoperative history and physical examination and planned surgery. Thank you.
Thank you. It's a very nice presentation, giving most of the theoretical descriptions that are required to understand hemostasis. But one thing I find missing is about the so-called the coagulation cascade involving the extrinsic pathway, intrinsic pathway, culminating into the common pathway. was later on replaced by cell-mediated theory. I think you have not mentioned anything about that. So the current concept is to accept the cell-mediated therapy. Do you have any idea about it, Prof? What is cell-mediated theory of coagulation?
Extrinsic, intrinsic, and common pathway.
That is the old coagulation cascade theory. Then later on it was modified because it had some deficiencies of not able to explain the classical role of factor 7 and also why people with factor 12 don't have any bleeding. All those questions were raised which were not answered by the old theory. So they proposed a theory called cell-mediated theory, and so that was the which says that all steps are overlapping. It is not like the mathematical equation shown in the older coagulation cascade of extrinsic intrinsic. These steps overlap to each other. That is the main basis of that, and it is initiation, propagation, and amplification. That is how they describe. Instead of the intrinsic, extrinsic pathway and common pathway, they call it as initiation, amplification, propagation, and amplification. These are the three steps which are said in the extrinsic pathway. So I would like to just show you a PPT which I made about 5 years ago for a CME talk on Ether Day. I don't know whether I have shown it earlier or not. I'll just quickly go to that. Is it visible?
Yes, sir.
Yes, sir.
Right. So, hemostasis actually, the description, I'll go through rapidly because we have very limited time. The definition, we asked you what is coagulation or hemostasis. It's a process in which a series of reactions occur among coagulation proteins to finally end up in conversion of soluble fibrinogen into insoluble fibrin strands. This is the actual definition of coagulation. So you want ultimately the fibrinogen, which is a protein in the blood, to become, which is dissolved in the blood, to become insoluble fibrin strands. So actually it is this is how the whole thing happens, one pushing the other. And the purpose of coagulation is to maintain a balance between pro and anticoagulation pathways. This is a very, very important step in the nature. Otherwise, all of us will be having a thrombotic lesion somewhere or other. So in a normal, healthy vascular tree, you should have no thrombus formation when the blood is flowing. So the blood should not be allowed to clot. If it clots unnecessarily without any injury, it results in thrombus formation. So it is very important that we have a good balance between the pro and antithrombotic pathways. And the components involved, vascular endothelium, as you rightly said, which is the most intimate thing. It has got an intima, media, and the adventitia. So the intimal layer is made up of endothelium, which has got all this nitric oxide and other things. Then there is a media which forms the matrix, extracellular matrix. So that is, this matrix should be exposed by the removal or the loss of this endothelium when there is a damage. Then only the platelet will get addressed. As we rightly said, the endothelium has got a negative charge which will not allow, because the first step in clot formation is the platelet should come and stick to that place of injury. That is the basic thing. So normal platelets will not be allowed to come and sit on the endothelium because of the negative charge they have, and platelets also have negative, so like charges repel. So that is how it is, nature has made it in such a way that it will be causing this. And this collagen and macrophages, all these things, when they are exposed, von Willebrand factor is the one which attracts and brings the platelet to this area So second thing is platelets, and platelets, they are made from the macrophages, megakaryocytes rather, and they are devoid of nucleus, just like the RBCs, and that is why they have a very short span life of 4 to 7 days. And these are all the coagulation factors which are in the plasma. This is the third component. So vascular endothelium, platelet, plasma clotting factors, these are the three things which are involved in the coagulation pathway. And the mnemonic to remember the clot factors are precious party tonight, come let us sing, also call seniors, please have fun. So F is fibrinogen, P is prothrombin, and T is, as you see in the earlier thing, tissue thromboplastin, and cum is, I think, calcium, and the L is labile factor, S is stable factor. Like that, you can remember all these 13 factors with this mnemonic. Now, coming to the vascular endothelium, in a healthy, intact, there is an antithrombotic mechanism. We don't want the thrombus formation in an intact food vessel. So there are so many things which are important, and it is heparan sulfate, not heparin sulfate, which is has an anti-thrombin free factor, which prevents any clot formation. So these four factors, thrombomodulin, heparan sulfate, tissue plasminogen activator, and CD95, all these things prevent the platelet coming anywhere near the endothelium and getting stuck. So this is the antiplatelet effect, negative charge repelling platelets by synthesis of prostacyclin, nitric oxide, ADPase, anticoagulation effect by these mechanisms, heparin C and as well. But when it is injured or damaged, it becomes prothrombotic. You can see here, there is a damage in the endothelium. The endothelial cells are lost. You can find here also there is a damage, vessel wall injury is there. So immediately platelets come and get stuck there. Platelet gets activated, then more platelets come, which is called aggregation. The initial step of platelet adhesion is the sticking of platelet to the injured wall. That should be called adhesion. It should not be called aggregation. And once they get adherent to the injured wall, they get activated, which becomes then starts aggregating more platelets. Okay? So exposure to extracellular matrix, subendothelial space as collagen, von Willebrand factor, and platelet adhesion glycoprotein, and tissue factor which initiates coagulation is the expressed from fibroblasts in the extracellular membrane. Why it is called extrinsic pathway? Because it is outside the lumen of blood vessel. So these factors exist outside, not in the flow. Inside the lumen, it is not there. That is why it is called extrinsic. It is not extrinsic to our whole body. It is extrinsic to the lumen of the blood vessel, but within the other layers of blood vessel. And coming to platelets, they are derived from this. They are non-nucleated, and they have three methods of this is how the formation is happening. From stem cell, it goes into the colony forming units and all. Then there is a pro-megakaryoblast, pro-megakaryocytes, and then finally platelets. Now, how do they get adhered to that? See, once into vascular injury is there, von Willebrand factor is the bridging molecule between the extracellular matrix and platelet GP1B receptor. That is the first step. And this factor is very loosely bound there. It is not strongly bound there. And that is called the primary plug or hemostasis. And if it is not strong enough, it will cause further bleeding. So once when the platelet gets attached to that, it gets activated. And the platelet has got two types of granules. One is called the dense granule, another is called the alpha granule. And from there, these factors are all released, which help to attract more platelets and cause the aggregation. So this step is very important. Only when this activation happens, it will attract more cells and cause activation. So this is how the aggregation happens. When platelets get activated, they attract more platelets, And in addition to surface receptors of platelet membrane, that is GP, 2B, 3A are expressed. And these are the receptors we target when we put a patient on anticoagulation therapy. That is dual antiplatelet agents. We normally call it as aspirin and clopidogrel or ticagrelor or prasugrel. All these things are acting at this particular receptor level in the platelet. So that forms a secondary hemostatic plug by the aggregation of further platelets. Then the plasma protein coagulation. They are synthesized mostly in the liver. Only these three factors, that is factor 8, factor 3 and von Willebrand factor are not produced in the liver. And factor 6 has been removed from the list. If you see, it will be 1, 2, 3, 4, 5, then 7, 8 like that. 6 will not be there because it was found to have been identified earlier and given another number. So again somebody else included it, and because both were same, it was removed. And they have used only Roman numerals for giving the number for the coagulation factors, and we should not write 1, 2, 3, 4 like our normal way. And again, these are all the various characteristics of blood clotting factors, and they are present in the plasma protein. Most of them are plasma protein. Most of them are produced in the liver, but factor 3 is produced in the tissue. That is tissue factor, which is responsible as in the cascade extrinsic pathway. Then some of them are produced in the liver as well as platelets. Some of them are antihemophilic factors produced in the lung capillaries also, and factor 30 is produced in bone marrow also. So these are the important things, and how they help in the various process is also given. So this is the what is called the classical pathway. The extrinsic, intrinsic and final common pathway is called the classical pathway, which was originally described. And this is the various steps by which it comes to activation. The damaged surface activates initially fibrinogen and kallikrein, and makes all the dormant inactive plasma proteins into active proteins. So once a 12 becomes 12A, it means it is active. Similarly, 11 becomes 11A means it has become active. So 9, when it becomes 9A, it's again active. Like that, it gets activated, and then the most important factor is the 10A. And through this 10A only the common pathway starts. And finally, it has to end up in conversion of fibrinogen into fibrin and cross-link that fibrinogen to make it more stronger. If it remains just as a fibrin clot, it will get dissolved. And when fibrinolysis occurs, they break this cross-link. And imagine you building a house, you put the bricks one by one without a cement. That is the initial stage of fibrin clot. But if you put a cement and then put the bricks over it, it will get stuck to that like that. So cross-linking means it is making it more stronger, and the breakage is done by the fibrinolytic plasminogen. So this is how the injury happens. There is a contact, then all these things. Very simple way to remember this pathway. And pitfalls of this classical pathway is described using in vitro methods. They tried it all in the test tubes. All the testing was done with the laboratory in the test tubes, and it failed to reveal the role of factor 7 in the integration of extrinsic and intrinsic pathway in vivo. How it is happening in the body, it failed to reveal. It also offers no explanation as to how deficiency of factor 12 does not cause undue bleeding. And why in hemophilia there is no support by the thrombin formed to control bleeding. All these questions were not answered by this older method. So hence the current concept of cell-mediated pathway. The cell-based mediated or pathway was proposed by this lady, Maureen Hoffman, in 2001. And all reactions are said to take place on the surface of two different types of cells, namely the platelets and cells with tissue factor. This is the basis for this particular thing. They say they are cell based because these cells, these two different types of cells are responsible for the entire coagulation pathway, and those cells are platelets and cells with tissue factor. The cells which have this tissue factor are fibroblast and smooth muscle cells, and occurs in three phases which overlap each other. That is the next component. So what are the three phases here? There is a initiation phase where there is a damaged tissue factor bearing cell, and that reacts to cause all these changes. Then there is amplification and propagation. So these are all the various factors that are used. So initiation, tissue factor plays a major role in the association of factor 7 in attracting platelets, also triggering plasma mediated reaction. Then there is an amplification where activation of factor 10 leads to thrombin generation from prothrombin to, and propagation, more thrombin is generated. Instead of saying more aggregation of platelets, here the propagation is by more thrombin generation. So this is one easy way to remember the steps. First you write the target, which is factor 10, by putting an X. Okay, this is how first step. Second step, you write the numbers from 12 to 8 and exclude 10 because you already put 10 here. Write the numbers from 12 to 8. So 12, 11, 9 and 8 are written. That is the step number 2. Step number 3, write factor 7, which is the extrinsic factor pathway. And step 4 is draw the common pathway where you have to write 1 into 2 into 5 is equal to 10. So these are the 1 is fibrinogen, 2 is prothrombin, 5 is the other factor. With all these things, the common final pathway comes. So this way you can remember all the steps of the original classic pathway. Now, applied physiology, non-Willebrand factor deficiency causes bleeding due to failure of primary hemostasis. As I said, because platelet is attracted only by the presence of non-Willebrand factor in the extracellular matrix area. And platelets can be deficient in number or in function, which can also lead to failure of clot formation, resulting in excessive blood loss. And plasma coagulation factor deficiency results in failure of progression of clotting cascade, leading to blood loss. Now, failure of anticoagulant factors or excess of procoagulant factors can lead to thrombus formation. So, why we develop thrombus inside is we are not preventing the coagulation. The anticoagulant factors are not there, or the procoagulant factors are more. Primarily, it is the deficiency of antithrombin 3, protein C, protein S are the common causes. And excess of antiphospholipid antibodies and homocysteine also promote thrombosis. That is why nowadays we always check people who have a tendency for developing atherosclerosis or thrombotic event. We are now checking homocysteine routinely in all the evaluation. Rarely, primary thrombocythemia, where the platelet count is abnormally high, can also cause spontaneous thrombosis. Now, when you want to evaluate the coagulation status, you have to do history taking, lab-based test, point of care test. So, when you want to take the history, you must conduct a carefully taken history is more than enough to assess the coagulation status. That is why when Rao completed that, always testing is not required, because we can always find out. A carefully taken history will help to assess the coagulation status. And the alteration of coagulation may be in the form of either undue bleeding tendency or a tendency for thrombus formation. These are the two antagonistic conditions that can happen. So, what questions you will ask for evaluating whether they have undue bleeding disorders? For that, you must ask for excessive history of bleeding during either trauma or a previous surgery, need for any blood transfusion because of this bleeding or re-exploration to control bleeding. For example, a child not properly evaluated post-tonsillectomy bleed. Even after exploration, if it continues to bleed, then only you think of some thrombocoagulation deficiency. So that will give a good clue. Frequent spontaneous epistaxis. A patient who has a previous history of epistaxis, you have to do the bleeding testing. and oral bleeding during routine brushing or during any dental procedure. In female patients who have severe menorrhagia or postpartum hemorrhage, spontaneous hemorrhage into joints like in cases of hemophilia, or age of occurrence. What is because younger age group we always take more care. History of drug intake, aspirin intake or NSAIDs, herbs, fish oil, garlic. This garlic is very important because people who take garlic regularly, it almost acts like an antiplatelet agent and causes more bleeding. And coexisting diseases like renal, hepatic, thyroid, and bone marrow disorders or malignancy. So these are the questions you have to ask if the patient is having a bleeding type tendency. On the contrary, if the patient is having a thrombotic tendency, is the patient obese? Obese patients, as you know, have tendency for venous thromboembolism. And is the patient undergoing an orthopedic or major abdominal surgery where they can be recumbent for quite some time, or if the patient are oral contraceptives. Ladies who take oral contraceptives, they have tendency for thrombus formation. And is the patient pregnant? Pregnancy is a procoagulant. It's a thrombotic state. And the patient being immobile for long, history of malignancy or on chemotherapy, which is also prothrombotic, or history of prior DVT, history of angina, or history of previous stroke. All these things indicate that the patient has got thrombotic tendency. Now, what are the indications for lab tests? If preoperative history reveals significant symptoms of bleeding disorder, you have to do lab tests. In cases where major surgery with possible chances of bleeding is anticipated, like cardiopulmonary bypass, you have to do lab tests. Or in patients who are not able to provide a bleeding history, but you would suspect clinically to points whether it is a bleeding or thrombosis, then also you have to do this test. Now, if any bleeding disorder or thrombotic tendency detected preoperatively, underlying mechanism must be ascertained before proceeding with surgery, especially in elective cases. Now, lab-based measurements, which he mentioned, lab platelet count is the first and foremost lab-based technique that test that you do, and what are the various ranges at which it causes the bleeding. And the second test is bleeding time, because it uses the platelet function. Earlier we saw the quantity of platelet in the blood. Bleeding time tells about the quality and functional status of the platelet and primary hemostasis. And it is a very simple method. Just by pricking the hand and then timer is used, and you start applying a blotting paper, and you can see the decrease in the clot formation and stopping of bleeding. So this is how the bleeding time test is done in the lab. And the prothrombin time helps to assess the extrinsic and common pathway. So value expressed in four ways, either with the PT as the control value, or PT as INR, or PT ratio, or PT index. These are the four ways it is done. And this is the method how it is done. You can take a citrated plasma, because plasma only contains all the coagulation factors. Once you remove the coagulation factors, it becomes serum. So the citrated plasma, which is preventing the coagulation, to which you add calcium and thromboplastin, and then see the action of all these things to find out the time it starts clotting. And INR is introduced standardized, which he mentioned, because the addition of the tissue factor in that is different from various labs. So various standards of tissue factor are used in different labs. So in order to standardize, INR is calculated by the following way. It is PT test by PT control into the standardization. That is also to be ISA is a numerical value representing the responsiveness of any given commercial agent relative to the international standard. So that is the correct formula. PT test divided by PT control multiplied by ISI. And normal value is 0.8 to 1.2 seconds. And the fourth thing, APTT, which is also a test of intrinsic and common pathway. Normal value is 35 to 35 seconds. Abnormal value indicates deficiency of most of the coagulation factors except factor 7, which is tissue factor, which is responsible for extrinsic pathway. And for this, again, you take the citrated plasma and then add calcium, kaolin, phospholipid, and then you do the coagulation screening. That is how the whole thing starts. And the fifth thing is the thrombin time, which helps to test the function of status of thrombin and fibrinogen. Normal range is 15 to 19 seconds. And this thrombin time test bypasses factors 2 and 12, measures rate of fibrinogen conversion to fibrin. And procedure is add thrombin with patient plasma, measure the time to clot, and the source of variable factors in this testing are the how you obtain the thrombin, that also modifies the value. Now the reptilase time is done when TT is prolonged. This is only this test is the additional test to be done if you find the thrombin time is abnormally prolonged. You have to distinguish the following condition. If the TT alone is raised with a normal reptilase time, it indicates excess of heparin in the blood. If you have raised thrombin as well as raised reptilase, it indicates low fibrinogen or fibrinogen degradation product. And the normal value for reptilase time is 14 to 21 seconds. And as he said, it is the barotoxin, which is taken from this snake. That is what is added, and this is because it's a reptile. It is called reptilase time. And anti-10A factors assay is used monitoring the activity of low molecular weight heparin and indirect 10A activities, which also he mentioned. And fibrinogen level is very important, especially in postpartum hemorrhage. This is a very important test to assess the success of your treatment. Normal range is 160 to 350 milligram per deciliter. So more than 350 is a normal range. 160 to 350 is good. Less than 160 is dangerous, and this could be due to reduced production by hereditary or hypofibrinogenemia or liver disease, or it can be due to increased consumption as happens in DAC and fibrinolysis. Test of fibrinolysis, they are dissolved or clot from products, and one component of this is D-dimer, which has a 2D fragments of fibrin protein joined by cross-link. The FTP value increases in advanced liver disease or exogenous thrombolysis like fructokinase, DAC, or during cardiopulmonary bypass. And D-dimer values increase in DAC, DVT, and pulmonary embolism. And D-dimer is also important in anaphylaxis. When you have a anaphylaxis, you are supposed to take blood and keep it assess it for tryptase and D-dimer, which are indicator of anaphylaxis. So the only way we can prove anaphylaxis is by the presence of tryptase and D-dimer. And just as the tests are done to assess the bleeding tendency, some tests are done to assess the thrombotic tendency also. So thrombophilia can be inherited or acquired, which are called factor V laden mutation, prothrombin gene mutation, deficient protein C, S and Z, antithrombin deficiency. All these things are anticoagulant factors. If they are not deficient, then you will have coagulation or thrombosis. And acquired conditions can be detected by antiphospholipid antibodies, estimation of homocysteine level, as I said earlier. And coming to these are the four earlier things are all lab based. And because why we wanted to switch over to point of care or bedside testing is the drawback of lab based tests is to reduce the time delay, especially in trauma. And there is a severe hemorrhage and you want to do transfusion, you want to assess the coagulation, patient is going on bleeding. Every time sending the blood to the lab and waiting for the results, assess the time delay in the treatment. So that is the first reason. Second reason, avoiding testing of plasma at a standard temperature. So you always take it to the standard temperature and you do it in situ as it is. and lack of information on platelets. Majority of the unless you do a specific platelet count or the platelet functional assay, you will not be able to find the real status. So advantages of point of care testing: results are provided faster, less volume of whole blood is used here. Here mostly we use the citrated plasma, whereas here we can take the blood and directly use it put it in the machine, and you require hardly 0.3, 0.5 ml, or not more than that, and less transportation hazards, and helps in blood component and drug therapy. And with these presently available devices, they can classify them into monitoring heparin anticoagulation, measuring the intrinsic ability of the blood to form clot, or you can assess the viscoelastic properties of coagulation. And platelet function monitors also have now come as a bedside or point of care testing machine, and clotting factor tests are also now available. So all the four things have been included into the bedside assessment. So functional assay of monitoring heparin and coagulation, which is commonly as an activated clotting time. Those who have done cardiopulmonary bypass surgery or cardiac surgery are very familiar with that, and it is low advantages are low cost, simple operation, all these things you know. And this is the machine which displays the time. So we want to raise it to 2 or 3 times before the cannulation in cardiopulmonary bypass surgeries by giving heparin. So it is mainly to monitor the heparin anticoagulation is the activated clotting time. The second thing is high dose thrombin time, which is another functional assay of heparin anticoagulation, and prolongs reflexivity anticoagulation by heparin. The viscoelastic measures of coagulation are thromboelastography, analyzing and displays all stages of clot formation, right from the beginning to resolution. So at what time exactly the liquid blood becomes a semi-solid clot, and then how it becomes a firm clot, then how it breaks down into again a liquid clot. All these stages are analyzed. Analysis in the interaction between platelets, fibrinogen, and coagulation, and factors use only 0.35 ml into 2 cups and gives a cigar-shaped graphical display. And this is the thromboelastography. You can see this is how the whole thing. So here the pin is rotating inside a cup, and then you get a graph like this. So the reaction time from where the clot forms, the kinetic clots, then there is the angle, the maximum amplitude, and then it starts breaking, lysis up to that. So coagulation and fibrinolysis all are measured in this. Then tech values are interpreted, and what is the correction you need. If the R time is prolonged, this is a viva question or your hospital question also. So the tech value R prolonged, coagulation factor problem, plasma you have to transfuse. If it is a decrease in alpha angle, just to get you this is the alpha angle. This is the, so just remember these words here. This is the reaction time. This is the achievement of certain firmness of clot. This is the alpha angle. This is the maximum amplitude. So based on that, decrease in alpha angle means no thrombin and fibrinogen. So you have to give cryoprecipitate or you can give fibrinogen also nowadays, which is available. Decrease in maximum amplitude, that is the strength of the thing. It means it's a decreased platelet function. That is, so unless more platelets aggregate, you will not get a maximum amplitude. So platelet transfusion and DDAP, which is activator of platelet, can be given, and raised estimated percentage of lysis. You have to give tranexamic acid or so these four things can be detected, whether it is a coagulation factor deficiency, whether it is a thrombin deficiency or fibrinogen deficiency, platelet, or lysis. And the rotation thromboelastography is a modified version of earlier introduced. So TEG was introduced first, then it was changed into rotation, ROTEM. Unlike TEG, which uses kaolin, It can be used in the presence of heparinization also, as the cups contain heparinase, which will counter the effect of heparin, helping to identify the residual heparin effects as well as rebound heparin effect after removal with hysterectomy. So the graph you get is almost similar to that with a slight modification, and the wordings are also little different. There you said reaction time, K time, amplitude. Here it is clotting time, clot formation time. Alpha angle is the same. Amplitude after 10 minutes. Maximum clot formation, lysis, maximum lysis. So these are slight different terminologies that are used, and this is how that machine looks like. And this is another newer machine called sonoclast. A vertical vibrating probe is inserted into only 0.4 ml of blood. The impedance of its vibration is produces the plot, and it is called a signature. So this again can be asked in the OSCE, where you have to identify this sonoclot signature is the way it describes. Unlike the cigar-like graph of that, here you have the R1, R2, R3 prime and plot retraction and plot rate. All these things are done. And then platelet function monitors are also now available, which are able to measure the adhesion and aggregation ability of platelets, useful detecting aspirin-mediated platelet dysfunction or von Willebrand disease. Hemodilation and thrombocytopenia may produce. And this is how the Innovance PFK 100, which is a platelet functional assay machine, which is available. Then clotting factors test. Of course, you can do PT, APTT, INR routinely in the hospital at bedside for patients on warfarin therapy and also for surgical patients. And vascular endothelium, platelets, coagulation factors are the backbone of coagulation. Balance between the pro and anticoagulation pathways is important for bleeding and thrombosis. Cell-based pathways seems to be correct way to describe coagulation to replace classical pathway from textbooks. Diligent history taking is what is needed for majority of the patients, and this is time is not far away for POC test to replace traditional lab-based tests. This is what I said about 5 years ago during the presentation, and now all of you know that thromboelastography has come into as an important tool both intraoperative and postoperative, especially after the liver transplant cases becoming more frequent. This has become the method of identification. Okay,